This conference will now be recorded.
All right, well, thank everybody for joining us here today. My name is Chad Worley. I'm the physician liaison for Lurie Children's Hospital. And as you know, I represent the north side of the city and the north suburbs. And we are here today to introduce our otolaryngology department that's going to be up in Skokie, and more specifically, Dr. Laura Rosenthal. And I encourage you to make comments and ask questions in our chat room while this is going on today. This is being recorded and will be shared, so you can share it with your colleagues who aren't able to attend this meeting today. Just know that there is information that shouldn't be shared with patients, so it should just be shared with your colleagues. So with that, we're going to be introducing Dr. Kathleen Billings, who is the clinical practice director for otolaryngology, and our division head, Dr. Dana Thompson, who's the division head for otolaryngology. So Dr. Billings, will you please take it away?
Yes, hi everybody. Thanks for joining this afternoon. I just wanted to give a brief update about our practice so you can familiarize yourself with members of our group and our locations and a little bit of general background about our group. So we'll go to the next slide. As Chad mentioned, Dr. Thompson is our division head. She's also vice chair of ambulatory practice at Lurie Children's. Her specialty interest is in airway reconstruction and aerodigestive. She was integral in the startup of our aerodigestive program here at Lurie Children's. Next slide. As Chad mentioned, I'm our clinical practice director. I also have interest in some otology. I work in the multidisciplinary clinics here with our Turner syndrome patients and PCD patients. And I'm also the physician lead for our single visit surgery program for ear tube placement. Dr. Rosenthal is a specialty interest in VPI and 22Q. She has specialty clinics here at Lurie in those areas. Dr. Rosenthal, along with Dr. Belika and Lavin, will be our physicians that will be heading up seeing patients at our new location in Skokie. Dr. Rosenthal will be speaking to us on speech resonance issues in children in just a moment. Dr. Belika will be giving a lecture in December. We hope you can join that as well. And he's going to be talking about advances in airway and sleep surgery. His interests are in airway reconstruction and aerodigestive as well. And Dr. Lavin next month will be giving a lecture on pediatric sinus disease, and that's one of her areas of interest. She also runs our trach clinic at Lurie. Next slide. Dr. Schroeder is Vice Chair for Education for the Department of Surgery. He also is our Fellowship Director. He's a specialty interest in fees and dysphagia. Dr. Rastatter, Matalozzo, and Johnston are our head and neck team. They're one of the most outstanding groups in the country in this area, and I'll talk to you a little bit about them later. Next slide. Dr. Young and Dr. Hoff are our otology team, our cochlear implant folks. Dr. Hoff also has a specialty interest in endoscopic ear surgery. Dr. Ida is Vice Chair of Operative Services for the Department of Surgery, and he has a specialty interest in airway reconstruction, aerodigestive as well. We also have a new hire, Dr. Gadar Sohi, who came to us after his fellowship in Denver, and he's going to be starting up our sleep surgery program here, and he also has an interest in craniofacial and VPI as well, and we're excited to have him in the group. Next slide. We also are fortunate to have 6 PAs on our team. They work with us on the inpatient side, on the ambulatory side, and some of our satellite locations as well. They are often the first line for during the work week, seeing patients in the emergency department and inpatient consultations. They've been a really wonderful addition to our practice. They have really helped and improve our ability to provide access to patients by working with us in high volume clinics. They have independent clinic capacity as well. So they've been wonderful to have in the group. Next slide. So who we are, we do about 6,000 surgical cases a year and 23,000 ambulatory clinic visits. Some of the unique things about our group that I really wanted to point out, in terms of otology, we have the largest pediatric cochlear implant program in the country. We're also a leader in endoscopic ear surgery with Dr. Hoff. He's one of the few pediatric otolaryngologists that has mastered that art. And I wanted to talk about our head and neck group as well. Dr. Johnson is one of the few pediatric otolaryngologists in the country doing transoral robotic surgery. And it's amazing work that they're doing. And our thyroid program with collaboration with our endocrine folks here at Lurie has one of the largest practices in this area in the country. They're well regarded nationally and even internationally. Also, we have a very large congenital neck mass practice here with probably one of the largest series of patients with thyroglossal duct cysts in the country. We have an amazing aerodigestive program. It's now the third largest in this country. That's been built up under Dr. Thompson's leadership, along with Dr. Idas, Valiga, and Laban over the last several years. And we have a wonderful collaboration with the GI team as well as the pulmonary team here at Lurie. We also have championed streamlined care and access via our single visit surgery program here at Lurie. We're one of the first places in I think the first otolaryngology group in the country to perform single visit surgery for tympanostomy tube placement, and we hope to expand that program as well. Next slide. Our locations are shown here. As you see, of course, we all practice out of Lurie Children's. We have satellites in Northbrook. We have a surgery center that opened up there last year as well. We see patients at the Lake Forest Outpatient Center, and at Westchester, we have a surgery center there as well, as seeing our ambulatory patients. We also have practice locations at Clark Deming in Lincoln Park and New Lenox near Silver Cross Hospital. Next slide. And we're very excited about our new location in Skokie. And it's off of Toohey Avenue here, and this will be opening at the end of November, and we will start seeing patients there likely no later than January 2021. We're excited to get out there, and as I mentioned, Dr. Rosenthal, Laban, and Valiga will be starting out there either by the end of the year or early next year. Next slide. Family-friendly hours, we do our best to improve access to our patients. We have family-friendly hours at most of our satellite locations and at Clark Deming. We also have operative time. Dr. Laban does third Saturday morning operative time at Lurie Children's to help provide better access to our diverse patient population. Next slide. To improve access and convenience, we also have several things happening. MyChart scheduling, of course. One of the things I also wanted to mention is decision tree scheduling. We started this in our group back in December of 2019. And this method of scheduling allows patients to get into the right doctor, the right location, the right time. So for example, we know that some of our patients need to be seen more urgently, babies with stridor, newborns with tongue ties who need frenulectomies. So if those patients call, we know they need to get an urgent appointment slot. So our system is built to accommodate those patients. Like I mentioned, our single visit surgery program has improved access. We can get patients in very quickly or suffering from otitis media to get tubes in. And telemedicine. I mean, telemedicine is something new for many of us, and we're exploring how this can really be an adjunct to our practice and improve access to our patients. Next slide. Partnership opportunities, our single visit surgery program, of course, we're doing with tympanostomy tube placement. We're also interested in exploring how else could we advance this program to manage adenotonsillar disease like chronic tonsillitis or sleep disordered breathing, and any other areas that might be intriguing to us by some sort of combined same day or telemedicine approach. So that's an area that we're really interested in exploring. Also looking to the future of telemedicine after, the COVID situation settles down, what does telemedicine look like us for the future? We think it's a great way to broaden our outreach to the suburbs and contiguous states, particularly for our complex patient population. We also would love to know how we can best serve you via telemedicine by, for example, having a telemedicine doctor of the day type of scenario. One of the new projects at Lurie is advancing our digital front door. That's improving access for MyChart and MyChart scheduling. Most of our decision trees will be going into MyChart, so patients will have the option to schedule online if they're logged into MyChart or have access to MyChart. And hopefully that access will broaden over time under the guise of the digital front door team here at Lurie. Next slide. And finally, these are the ways you can communicate with us. If you want to put this phone number in your phone, this is the Lurie MD number. You can contact an attending physician urgently at any time, or if you just have questions. Any CIN member is eligible for Rapid Connect option as well. And also for Community Connect providers, the Epic In-Basket is an option for communication as well. So that's my brief summary of our practice. Thank you for your attention. And please, if you have any questions or comments, you can put them in the chat box and Chad will get those to us. And Laura will start her presentation on speech and resonance issues in children.
Okay, thank you. Thank you, Kathy, for the introduction. You guys can hear me okay? Okay, I'm going to share my screen. Okay, so Kathy, it was a great introduction. I personally am a general pediatric otolaryngologist, but as with many of us at Lurie, we tend to sub-specialize, and my superpower is helping kids with speech disorders. So I chose to talk to you all today about resonance disorders specifically, and what's called velopharyngeal insufficiency, or simply where too much air goes through your nose when you talk, which can affect speech significantly. So feel free to ask questions. Please talk amongst yourselves, open it up for a discussion. I'm happy to be interrupted. There's a chat function that you can use as well. So we'll talk quickly about the role of otolaryngology and speech delay. What is a resonance disorder? What VPI is and how it's diagnosed? And for the pediatrician, mostly just to pick up on what it sounds like. So I have a lot of audio and video, and you can see what's happening, but also make sure to listen to what the speech sounds like. So I just thought the simplest way was to go through a couple cases. So in general, there are all kinds of reasons someone might end up in my office for speech delay, and there are things that we can do like frenulectomy, ear tube placement. Of course, if there's a hearing loss, that can be associated with speech delay. Sometimes tonsils and adenoids can impact the speech, and they cannot cause people to sound really stuffy or muffled. But not being able to close that space at the back of the mouth, the back of the nose, would also cause speech problems called VPI. So you'll see it mostly with patients with cleft palate, but we'll talk about some other patients that may be at risk for this as well. And then, of course, if someone's having trouble with speech, they also have to have, they may have some other laryngeal or airway pathology or even pulmonary problems. So speech delay broadly often means a communication disorder. What we're specifically targeting is setting aside language disorders, and until someone has language, you can't really assess their speech. But there are still there is still a large portion of patients who in school age have articulation disorders. And so this would be a specific type of articulation disorder called a resonance disorder. So most of the sound when you speak comes out your mouth, and there are only very few sounds where the speech actually comes out your nose. So what your voice sounds like is very much not just your vocal cords, but the shape of your airway from your mouth and your pharynx and your nose, but also your sinuses. And a lot of the quality of an individual's voice and what makes it unique is the way it resonates through your head. So like I've been told that my sister and I sound exactly the same, and it's probably like our sinuses and everything are probably shaped exactly the same way. So when you speak, all of the most consonants and vowels come out your mouth, and you require on what's called velopharyngeal closure. Velum is the palate, pharynx is to really articulate things well. So if you just think about it, if you close your mouth and you go all of the air comes out your nose. If you say N or NG, those two sounds also, all of the air comes out your nose. But for every other sound that you make, the palate, if you can see the cursor right here in green, like the palate has to hit the back wall of the throat to cut the air off so it doesn't go up your nose and it all goes out your mouth. So our speech pathologist used to give this presentation, and so we've had this slide for years on what hypernasality is. So you're probably all familiar with Fran Drescher, but here's just a little sample.
Look over your left shoulder and tell me if that's...
Hello, I'm Fran Drescher. I'm checking in. Hey, excuse me, Miss Fran Drescher, but I am your biggest fan.
So just to remember what that sounds like, obviously her speech is very intelligible, but she classically has like too much air come through her nose. The opposite problem can occur also. It's basically when you have a cold or some sort of nasal obstruction, you could sound super stuffy, but really stuffy speech is actually really easy to understand, whereas hypernasal speech can often be really difficult to understand. I've decided to add a kind of more modern example. So the pediatricians are probably now more familiar with Ariana Grande, but this is Ariana Grande, and this is what she sounds like.
Laugh like that.
Poppy's wearing sunglasses.
Dang it.
So she's kind of doing it purposely there. And again, their speech is good, but we're going to see some examples of poor speech intelligibility with VPI. So again, we kind of want to separate out where patients have a true anatomic or structural problem, or what's called velopharyngeal insufficiency, which we could treat surgically, or is there another problem like a motor problem or neurological problem? This we would call velopharyngeal incompetence. Someone might fatigue, or they just might not be quite strong enough. And that we can sometimes treat that with surgery easy also, because it just makes it easier to speak. But then we also have to figure out if someone's VPI is functional or mislearning. So Ariana Grande does it purposely. She can speak actually normally, but she, for this show, she kind of did it purposely. Sometimes kids can also just mislearn. We might, like an astute speech pathologist can pick up on this and retrain them to speak correctly when anatomically and neurologically they're able to. So when that all we need all those three components to work. When you don't, that's when you have VPI. So what we do in the VPI clinic, it's a multidisciplinary clinic. I have the speech pathologist and I work together, and first they do what's called a perceptual speech assessment, and they have many tools to figure out whether or not someone has hypernasal speech or VPI. They'll write a report. So in our notes, you would often see something like this, and we can just go through kind of the first example or a case example. So what the best tool, the best objective measurement is something called the CAPS or CAPS American, because different cultures, different languages, different regions, like in the Midwest might sound more nasal than like the East Coast. So this is American as opposed to like British or other speech. So this is a patient who has his first VPI evaluation. We measure speech acceptability. His speech is very unacceptable. We measure voice, which for my patients is usually normal. Hypernasality, so mild, moderate, severe. So this patient came in with severe hypernasality. Hyponasality, because you can actually have a little bit of both, was totally normal, and you could frequently hear air or turbulence coming through his nose. So I'm just gonna, it's hard for me to see my whole slide. Sorry, 1 second. Okay, so this patient is a 4-year-old, otherwise healthy male who presented with hypernasal speech after ear tubes and adenoidectomy. This was the second set of tubes. He had been enrolled in speech therapy when he was younger, but had normal speech prior to surgery. And if you go through his history, it turns out that in infancy, he did have some nasal regurgitation, so food would come through his nose as an infant, or milk. He had some reflux. He also had in infancy an extra digit removed. And then at 3 years old, he had otoplasty for prominent ears. So he came into our clinic with this VPI evaluation where he had unacceptable hypernasal speech, and he was scoped, had VPI. So the second thing we do is a nasal endoscopy, which we'll get to. And so he had a pharyngeal flap. After the pharyngeal flap, his speech was acceptable. So now all his scores have turned to 0, although he does have some mild hyponasality, which is usually an acceptable outcome. So he came to our clinic. We worked him up for his VPI. It can be just a complication of adenoidectomy, but if that's going to happen after adenoidectomy, there's usually a reason. So we sent a microarray, which was positive for 22q deletion. So if I have a healthy patient in the VPI clinic, they all get 22q testing because there's about 75% of the patients who are otherwise healthy, who don't have another known reason like cleft palate to have VPI. About 75% of them have a 22q deletion. So if the microarray is normal, then sometimes we'll think about additional workup as well, like an MRI or neurology consult. And we do sometimes take into consideration whether or not Chiari malformation may play a role. But this is after the speech pathologists do their perceptual. I'm getting a little message that there's a slow network connection, but are things okay? Okay, so this is a simple nasal endoscopy. We'll usually look at both sides of the nose. They're, typically unhappy for about a minute until the scope stops moving around.
Open your eyes. Look here. Now say ha, ha, ha. Nice job. P, P, P.
P, P, P.
Ba, ba, ba.
Ba, ba, ba.
Nice job. B, B, B.
B, B, B.
Ta, ta, ta.
Ta, ta, ta.
B will pull a rope.
The B will pull a rope.
So listen to the speech also. Some of the B's will come out sounding a little bit more like an M. A T might sound a little bit more like an N. I'm gonna fast forward a little.
Now say pa, pa, pa. Nice job. P, P, P.
P, P, P.
Ba, ba, ba.
Ba, ba, ba.
Nice job. B, B, B.
B, B, B.
Ta, ta, ta.
Ta, ta, ta.
B will pull a rope.
The B will pull a rope.
Buy baby a bib.
Buy baby a bib.
Your turtle ate a hat.
Your turtle ate a hat.
Do it today for dad.
Do it today for dad.
A little bit louder, I couldn't hear you.
Do it today for dad.
And then we usually do laryngoscopy, just make sure both vocal cords and everything else are good. There are some other things on exam for 22q patients who have that we look out for as well. But what we're doing when we do the nasal endoscopy, which occurs after the perceptual speech assessment, we take the patient to a room for nasal endoscopy. Speech and I are present together to see what happens inside while the patient is talking. And so we're looking for we're looking at for a pattern of how the pharynx actually closes. So at the bottom, you see the palate. At the back, you see the adenoid. This is the right side of the throat, and this is the left side. And so this particular patient, he has sort of a coronal pattern, and that helps us, if it needs to be fixed, it helps to guide our surgical care. And at the bottom, just to give an example, this is someone who has more of a circular pattern where you can really see the side walls come in as well. And this person has good palate movement, good sidewall movement, and just more of like a really small hole right in the middle where the palate's just not coming together, or the palate and the posterior wall. So the most common patient is someone who's on secondary palate surgery. So cleft palate has already been repaired, but they have continued speech problems. And it's about maybe 20% of patients who have a primary palate repair will need some additional surgery for their speech. So listen to this person speak.
Good try. All right, we're gonna do some of those words. We're gonna say pup, bib, tat, dad, hook, hi.
So words like dad come out more like nad. I'm gonna skip forward a little bit.
Then let's count from 1 to 20.
Yep. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18.
So her speech, she has some good articulation, and so that's what the speech pathologists look out for. If someone seems to have good articulation, but they're still having significant trouble with speech, we think about VPI. Of course, it can also be concurrent with articulation problems or articulation. They can compensate for an articulation and create an articulation problem when they have VPI. So we do often see them all mixed up and muddled together. So this is the typical report you'd see from our clinic, where they have the caps and then an evaluation from nasal endoscopy. And this is a patient with a submucous cleft palate. So I wanted to point this out as a patient who's at high risk for VPI. You can see here that she has a bifid uvula. You'll see it better in the video, but there's a kind of a gray line in the middle where the mucosa of the palate has come together, but the muscles have not. And this is what she sounds like.
Do it today for dad.
Do it today for dad.
And you can see a notch on the palate right here.
Or a cake.
Give Aggie a hug.
You and eat a hug.
Okay, we'll do a couple sounds. Pa, pa, pa.
Pa, pa, pa.
Ba, ba, ba.
Ma, ma, ma.
Ta.
So ba, ba, ba sounds more like ma, ma, ma. Or to stop a sound, she might make the sound stop at the back of her throat, as opposed to like the back of her nose.
Ta, ta.
Ta, ta, ta.
Da, da, da.
Da, da, da.
Ta.
Okay. So the patient with, there are a variety of ways to do this, but one of the surgical options is to do what's called a furlopalatoplasty, or lengthen the soft palate. I think most of the time when we present to non-surgeons, they always ask for fewer surgery photos, and surgeons always ask for more surgery photos. But this is just one shot from surgery where we do a Z-plasty, and basically if the palate is sitting like this, we kind of turn it so in a diagonal to make it longer. So this would be really short, and this would be really long. And you can see that the distance from the junction of the hard and soft palate to the tip of the uvula here is a lot shorter than the junction of the hard and soft palate here all the way to the tip of the uvula down there. This is another case of an 8-year-old female who came in with decreased intelligibility and hypernasal speech. She is a healthy female with tonsillectomy and adenoidectomy at 7 years old, and after surgery, she had some trouble with her speech. This is what she or a little sounds like and what her exam looks like. This is the adenoid pad or scar tissue left from, we do see sometimes.
Puppy will pull a rope.
Puppy will pull a rope.
My baby a bib.
My baby a bib.
Your turtle ate a hat.
Your turtle ate a hat.
Do it today for Dad.
Do it for day to Dad.
Sissy saw Sally race.
Sissy saw Sally race.
Zoe has roses.
Zoe has roses.
She washed a dish.
Okay. I'm gonna kind of skip to the end in the interest of time.
2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay.
Puppy will.
So as she was healthy and her gap was pretty small, we decided to do a little injection of the posterior pharyngeal wall. So this is a surgery photo. We're looking from inside the nose, so the mouth is down below. This is the right side and this is left side, and this is that adenoid scar, but everything's like flipped upside down. And here we're just gonna bulk up that back wall with a little injectable material. This is hyaluronic acid, but there are a variety of options. So, okay. Okay, sorry. Just sticky slides for 1 second. I'm just having trouble advancing them. Might. Sorry, there's just a delay between what we can see and what I'm doing on my computer. But just, let me see if I can pull it up again. Okay, I'm just gonna go back. I have another computer set up for this kind of problem. So I'm gonna share my other screen. Can you see this okay? Yeah. Okay. So we, in general, like the take-home point is if someone's speech just doesn't sound quite right, but you can't really pinpoint what the problem is, please send them to us for an evaluation. I hope after this brief presentation that you feel like you would be able to more easily identify patients with hypernasal speech or patients that might be at risk for hypernasal speech, like patients with 22q deletion, cleft palate. Sometimes we see patients with neurofibromatosis. If there's a speech decline after adenoidectomy, although I definitely give it some time, like a good 6 months before passing any judgment on it. Chiari malformation or other syndromes. There may also be unique situations. I have operated on patients who play wind instruments, may have a really decent speech, but just don't have the strength when they're playing the flute, which can be really hard, or they may fatigue. And so, you know, I do have one teen who was incredibly happy after surgery because he could play his wind instrument much better. Nasal regurgitation of food is a much bigger problem as an infant, and I think most patients tend to grow out of it, but food can still come through the nose, and for whatever reason, it seems to happen with noodles. And I have one patient who really didn't want the noodles coming in her nose anymore. So we fixed her VPI surgically. You know, one downside, you know, in ENT, we, you know, kind of open holes, close holes. One downside to kind of closing this space down is that it can cause snoring or nasal obstruction or sleep apnea. So that's something that I screen patients for before. Most of the time it'll resolve after surgery. I have a few other slides for discussion if there's any interest in discussing anything, but I will just leave this one up. If you have patients that you'd like to be evaluated in the VPI clinic, we do typically start with a speech therapy evaluation, and specifically for a speech resonance evaluation. And I left the phone number up here. But patients can be directly referred to the VPI clinic, which again is where speech and I are there together. It's especially helpful if they have a known diagnosis of VPI. They may be have been seeing speech therapy for years, and the speech therapist has already confirmed that they have some VPI. Often patients come in saying, I've been told I have nasal speech. And I am always like, well, is it hypernasal or is it hyponasal? And they're like, I don't know, it's nasal. So we kind of have to tease that out too, you know, and treat nasal obstruction if that's really the problem. It can also be, the scheduling can be done through my nurse directly. Her name is Nancy, and I left the nurse phone number up there as well. I'm happy to take any questions or referrals also by in-basket, my email or my cell, or as Kathy mentioned, also Rapid Connect. Are there any questions or anything?
I do not see any questions in the inbox right now. So if anybody has a question, they can unmute themselves, or we look forward to sharing the slide with you as well when the link is ready.
Okay.
All right, well, I think that's it then. I don't think there's any questions. This was great. I really appreciate everyone joining us. Dr. Rosenthal, thank you so much. Dr. Thompson, thank you so much. And Dr. Billings, I know you're not with us right now, but thank you for coming along. And if anybody has anything to add, go ahead and unmute. Otherwise, this has been great, and look forward to seeing this link sent to me shortly that you can share with your colleagues.
Thank you.
Thank you, everybody. Be well. Take care.